CHÉOS exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
Good afternoon. Welcome everybody to our Work in Progress seminar series. Delighted to see everybody here and welcome to the people online. My name is Amy Salmon. I am introducing this session and I will also be co-presenting with a colleague. I'd like to first acknowledge with gratitude that we are meeting today on the traditional, ancestral, and unceded homelands of the Musqueam, the Squamish, and the Tsleil-Waututh First Nations. We'll continue with a land acknowledgement related to the work when we proceed to the presentation. It is my great pleasure to introduce our valued colleague and our main speaker today, Dr. Rick Sawatzky. Dr. Sawatzky is a professor in Trinity Western University School of Nursing and is also one of our program leads here in CHÉOS and person-centered measurement, and will be presenting today on novel methods for equitable people-centered health measurement. Rick, shall I pass to you?
Great. Yes, thank you. Welcome, everyone. I'm really thrilled to be able to share this work together with Dr. Amy Salmon. And Amy is one of the principal investigators on the same project that we're going to be talking about today. She's an associate director here at CHÉOS and a clinical associate professor at the School of Population and Public Health at UBC. So we're going to be co-presenting, okay. And yeah.
I think we'll. Oops. Yeah. So to continue with the land acknowledgement, this is a project that's actually taking place across many organizations, health authorities, universities, community partner organizations at various places in Canada and internationally. But we've provided the land acknowledgement for our work here at St. Paul's Hospital. And we would also like to acknowledge with gratitude that Trinity Western University, where Rick is based, is located on the ancestral, traditional, and unceded homelands of the Stolo First Nation. Over to you.
Great. So today we're going to be talking about this, what I would view as a very foundational question that's kind of influenced the research that we've been doing for years, for the past 2 decades. And that is, how do we measure health in ways that reflects each person's unique lived experiences, culture, and social situation? It's a daunting question because often we think about measurements in terms of standardization, something that applies equivalently to all people. And the talk here, what we're talking about here today is that may not be such a valid assumption. And how do we then address that? The work we are doing, let me grab my notes. The work we are doing is grounded in what the WHO, the World Health Organization, calls integrated people-centered healthcare systems. And it's a shift from shifting our thinking from what's the matter with you to what matters to you. A shift in thinking towards people-centered healthcare. And to do that, we also need to shift what informs the type of healthcare decisions we make and how we make those decisions. Of course, often we make decisions based on clinical outcomes and on patient-centered performance indicators like wait times and so on. And that information is important. But we additionally need other information about how people are doing, about how is your care, about how are you doing, and about what matters to you. And there have been decades, of course, of research and development done on creating tools to answer these types of questions. This is not a new idea. The first tools were out in the 1960s already. So it's been over 5 decades of work, tons of clinical trials, tons of systematic review on the development and use of these types of tools. And they're often referred to as patient-reported outcome measures or health-related quality of life measures, tools for measuring predefined aspects of health or quality of life from a person's point of view. And we also have patient-reported experience measures that look more at healthcare experiences, like measuring aspects of respect and dignity, involvement in communication and decision-making, and so on. And they measure predefined dimensions of patients' healthcare experiences from their point of view. And then there's also so-called idiographic measures or individualized measures that really get at measuring, first identifying what matters to the person, and then measuring whether that's actually being achieved. Like goal attainment scaling might be an example of that. But except for the idiographic measurement approaches, the other two are typically developed from what we call in measurement a nomothetic point of view. Nomothetic has to do with what matters to most people, which may not be the same, of course, what matters to this person. And so they measure what matters to the average person. They treat all questions and answers as having the same meaning for everyone, irrespective of their individual differences in their social determinants of health or health conditions. And the fundamental assumption underlying these measures is that people interpret and respond to all questions about their health and quality of life in the same way. And this nomothetic measurement assumption is, of course, inherently flawed when the intent is to measure perspectives of diverse people, of their health and healthcare experiences, because it disregards important contextual social demographic data, especially from people who have been marginalized or underserved populations. We know from these decades of research that there are many individual differences that influence how people interpret and respond to questions about their health and quality of life. Social determinants of health, their health history, their healthcare experiences, personality, and so on. Just to give a couple of examples, do questions for measuring physical activity have the same meaning for different people? Are the same health domains equally important for different people? And are different dimensions of health relevant for some people and not for other people? And does a change in health scores have the same meaning for different people? All this introduces the challenge of measuring health of diverse people, which we've come to refer to as methods for equitable, people-centered health measurement. Conventional methods, to summarize, ignore differences in how people interpret and respond to questions. And ignoring such differences leads to measurement biases that reinforce inequities by concealing or misrepresenting how they view their health. Equitable people-centered health measurement seeks to use refers to methodological research that is essential for establishing equitable and exclusive approaches to measuring what matters in diverse populations. So how do we do this? Well, I've got to give a little bit of background. Not going to give much technical background, but really what we're talking about is measurement bias. Think, for instance, a scale for measuring depression. The CES depression scale includes this widely cited item about crying. And the frequency of crying is seen as an indicator of depression. But certainly there's many other individual differences that influence whether a person's going to cry or not. A person who has less propensity to cry would be at risk for being for having a measurement bias against them, for being under their measurement of depression being less prominent of depressive symptoms, whereas people who have more propensity to crying would have the opposite effect. And all this falls under the umbrella of research on what we call differential item functioning, or measurement invariance. Conventional research on measurement bias has focused on a priori defined differences be it gender or age or culture, where we compare certain groups of people as to whether they interpret and respond to questions in the same way. Equitable people-centered health measurement methods take this a step further by integrating statistical approaches to intersectionality research that attends to individual differences and how they interact, and truly understanding how people interpret and respond to different questions without necessarily making a priori assumptions. It's about gender, it's about age, or it's about culture. Intersectionality, of course, introduces a way more complex context. The conventional, so I'm just going to go back and forth between these two approaches. The conventional measurement approach is a one-size-fits-all approach. We have something that we're measuring, be it health, be it pain, be it emotional well-being, be it depressive symptoms. And we have a series of questions that we ask people, and from that we infer a measurement about their health. And those arrows, those lines with the arrows, have to do with the relationships between the questions and what we're trying to measure. And in the psychometric measurement theory, those arrows represent statistical relationships. If your measurement is a continuous variable, that relationship could be a linear regression, as in regular factor analysis. So if our measurement items are categorical, of course, we could use different types of models, typically logistic type of models, being a proportional odds model, as in an item response theory model or rash measurement theory. But the point is that we're relating items or questions about the construct we're measuring to what we're measuring, and that relationship is assumed to be the same for all people. And so our conventional approaches to examining that assumption is to test whether those relationships between the items or the questions and what we're trying to measure is moderated by certain variables. The evidence, or the equitable people-centered health measurement approach, takes this a step further and asks, well, what if we don't know what kind of factors are influencing how people interpret and respond to these questions over and above that which we're trying to measure? And we get at that by basically introducing the notion of latent classes. Latent means hypothetical subpopulations that are not directly observable. Yeah, so what if we don't know what's causing people to interpret and respond to the questions in different ways over and above what we're trying to measure, and how do we account for that? This is what the evidence, the equitable people-centered health measurement gets at, and it's basically does not assume that a one-size-fits-all. In other words, if you recall this previous slide, here we have known variables by which we moderate the relationship between the items and the questions, and here we have latent classes, unknown variables, that moderate the relationships between the items and the questions. And it gets a little bit complicated, so we're not going to go through this in detail right now. Otherwise, I think most of you might leave the room. But it's in a paper here if you wanted to give it a read. But the basic kind of conceptual idea is not complex at all. Basically, it involves in first establishing a measurement model. So this, what we saw right here, that's a measurement model as a first step. And that model could be a conventional factor analysis model, could be an item response theory model, graded response theory model, a rash measurement theory model, whichever model best represents your scale. Once that model is established, we want to examine whether that model is homogeneous or heterogeneously represented in a population of people. And we do that by incrementally adding latent classes that relax the assumption of those measurement model parameters, relationships between the measures and items being invariant. And once we've determined the number of latent classes, which is kind of analogous to determining the number of latent factors in factor analysis, except with factor analysis, we're looking at items, and with latent class analysis, we're looking at people, columns versus rows. So once we've established that, we want to assess the degree of measurement bias by comparing a one-class model, which assumes there's no measurement bias, to an X-class model or multi-class model that accommodates that heterogeneity. And the difference between those gives us a measure of the degree of bias. And then we want to explain, we want to understand what are the variables that are actually associated with this heterogeneity. And this is where this statistical intersectionality comes in. And then, of course, we really want to adjust for it a lot as well, so that we get adjusted scores that account for individual differences in how people interpret and respond to the questions. And if you wanted to get some resources on this, you could go to our website at healthyqualityoflife.com. We've got videos there, we've got an online learning module there, and papers there that explain all these ideas, both in terms of methodological applications, but also in clinical applications in healthcare. We've been focusing on home care for older adults, family caregivers, and kidney health, as well as developing a resource guide for practitioners. So our equitable people-centered health measurement methodology. And by the way, if you have a better shortcut for saying that, I would really appreciate that, because I keep stumbling over it. But we've done a number of studies, and I'm going to very briefly show you the results of a study that's already published, which was to examine the potential for using what we're calling those latent variable mixture models to reduce measurement biases in subjective health measurements using computerized adaptive tests. And again, let's just briefly compare. Like a computerized adaptive test is a test where you answer a question first, and then the next question gets selected based on your answer to the previous question. And there's a statistical algorithm between the two. It's not simply skip logic, but the first question puts you on a place on a continuum of the measurement scale, and then it selects a question that's close to where you've been located on that scale relative to the previous question. So that's a conventional computerized adaptive test. It is more personable in a way, because you converge on a fewer questions, and you're less likely to have to answer irrelevant questions. But nonetheless, it's a one-size-fits-all approach. The same model is applied to all people. And so as a result, you may be asked to respond to questions that do not matter to you, and your scores may be biased depending on individual differences that influence how you interpret and respond to the questions. The equitable people-centered health measurement takes this a step further, uses the computerized adaptive test methodology, but actually inserts into that prior information about a person's social determinants of health and individual differences in their health status. Looking at this differently, the conventional computerized adaptive test, if we think we're measuring, say, perceived health and quality of life, assumes that the population is homogeneous. We get a response. That data gets fed into the measurement model, and based on that measurement model, the next question is selected, and that goes round and round and round until it converges on a desirable criteria of precision. This is the nomothetic computerized adaptive test. The equitable people-centered health measurement says, no, hold it. There's other differences that influence how people are interpreting and responding to these questions. And those differences could have to do with a range of social determinants of health. They could have to do with a range of clinical health indicators as well, or interactions amongst them, or to do with things that we don't even know about. All that information influences how people respond to a question. That gets fed into a more complicated measurement model, a latent variable mixture model, and that model considers all the information, not only the information about the questionnaire that's answered below, but also the other information from the person to statistically determine which next question is most likely more relevant to this person. It's not an absolute thing. I'm quite intentional about most likely. We are in a statistical world here, but nonetheless, it's better than ignoring the information. altogether. And that then comes up with what we call an equitable people-centered health measurement score. In lay language, we often refer to it as a tailored score. Oh, there it is.
Mhm.
Code red, all clear. Code red, all clear. Code red, all clear.
Great, that's a relief. That information, of course, feeds back into people-centered healthcare. That's actually an important point, that people-centered healthcare piece, because it just alerts us to the fact that we're not measuring just for the sheer joy of measuring. Where, well, I think it's pleasurable, but not everybody might agree. But nonetheless, we're measuring with a particular purpose in mind, and that is, of course, always to have front and center. Now, we do have a prototype online that you can go to our website and try out. But before we go there, I'll just give you a brief overview of the study we've done. So we have applied that methodology in the context of a real data simulation study to develop a prototype. And that study involves these steps. We first fit the latent variable mixture model. We then examine, use that fitted model to original data to generate a hypothetical heterogeneous population. So it is based on real data parameters, but then we transitioned into a simulation study to generate more data. We fit a one-class unidimensional model, which is the conventional approach, the nomothetic approach, which ignores homogeneity. Then we applied the mixture model as well, and we compared the two to evaluate the degree of bias in a simulation environment. So our real data was based on 36 items that measure pain or discomfort, and the impact of pain on discomfort on one's daily life and leisure. And it's from an item bank called the CAT5DQL from Dr. Jacek Kopic, whom some of you may be familiar with, from the School of Population and Public Health. And our sample is a mixed sample of people from arthritis clinics and surgery, and a community-based sample. And we used, for those who are interested, we used Semajima's graded, two-parameter graded response model to fit. And that model looks something like this. So basically, we have we're measuring this latent patient-reported outcome score, which is pain in our case. We have a series of items here, and those items are connected to what we're measuring by a statistical relationship. That's the two-parameter graded response model. It is actually simply a proportional odds logistic regression. And we moderate that relationship, both the intercepts and the loadings, or in item response theory language, the difficulty and the discrimination parameters. They are moderated to vary across two or more latent classes. And we then generated the data. I'm not going to go into the details here. You could read the paper if you like. Like I said, we first fit the one-class model that assumes everything to be homogeneous. And we then went and applied that to programming a computerized adaptive test. And a computerized adaptive test includes stopping rules that says, hey, we now have enough information to make an informed measurement, and that's when the test stops. And in our case, our stopping rule was based on a standard error and a maximum number of items. We then save the data and we compare the results of a computerized adaptive test that ignores heterogeneity versus a computerized adaptive test that accommodates heterogeneity. And in our results, we found to program the test, the mixture CAT, we call it, the mixture computerized adaptive test, is based on 3 latent classes, which had a better model fit than the one-class model, which assumes or ignores heterogeneity in the data. And this was a mock-up, so we don't have a lot of background variables, but just to give you a sense, the latent classes differed with respect to age, with respect to whether people had arthritis or not, or whether they had another health condition, and whether they were community dwelling or from one of the clinics This is just meant as an example to say that these latent classes are not just hypothetical things. We actually could figure out who is more likely to be in which latent class. This had a pseudo R squared of somewhere around 20%. I haven't put it here. So it's not negligible either. And so here are the results. Here is because we have a simulation study, we of course have a true score. That's our simulated score. So that's on the x-axis. And on the y-axis, we here have the pain score that ignores heterogeneity in the data. And here we could see that, well, of course, there is an average straight line. We expect that to be, because nomothetically, on average, the tools should work pretty well. But we also see that at the 90th percentile and the 10th percentile, people are off by almost a half a standard deviation. And so 20% of people are above or below almost a half a standard deviation from their actual true scores. That's measurement bias. Now, if we just are just concerned about the average, that might not matter so much. But if we are concerned about those 20%, then that does matter because they're really misrepresented. And of course, in healthcare, we are concerned about the 20%. We know our healthcare works on average for most people quite okay, but there are many groups of people for which it doesn't work so well. So we got to move away from this nomothetic way of thinking to more of a people-centered way of thinking about healthcare. And so then we take the computerized adaptive test that accommodates this heterogeneity. And there we see that we now get a perfect line. Our measurement bias is basically almost gone. And I should have clarified the axes are standardized mean differences. So they're Z scores. They could be interpreted as well, there's Z scores. So this is showing that the computerized adaptive test hypothetically works. So all this brings us to our current project. Amy's
okay, thank you, Rick.
Thank you.
So often I speak without notes, and this is not one of those days. I thought, no, that's okay. I've got it. So here we are. So I thought maybe before telling you a little bit about the current project, I'd explain a little bit about how I happened to become involved with it, because I think it perhaps helps to ground some of this discussion for the non-specialists in the room, of which I am one. So one of the things that I value most about the environment for collaboration that we have built here at CHÉOS is the opportunity that it brings us to reach out to colleagues who work in very different areas, but who share our same values, our passions, and are motivated by similar concerns. And so in my case, one of the opportunities that arose for this collaboration came in the work that I'm doing with a team that is evaluating a large-scale system transformation effort to improve quality of life for residents in long-term care homes here at Providence. And so in the context of this evaluation of an intervention that aims to improve quality of life, one of the things that we had to ask ourselves quite quickly was, what tools will we use for regularly assessing quality of life amongst residents in our long-term care homes here and on Vancouver Island, populations that are very diverse within the care homes themselves and also between the care homes, because many of the care homes have evolved specific areas of emphasis that speak to the needs of the people who live in those homes individually and as a group. And so as an evaluator, as a person who does mixed methods work and who trained primarily as a sociologist and an ethnographer, I very naively thought that I could call my colleague, Rick, and say, Rick, we're doing this thing. What tool should we use? And Rick said to us, well, some tools are better than others, but we were quite surprised to find out that in fact, in what we thought was a relatively simple and straightforward way to assess a very common outcome that we're striving for across many sectors of healthcare in what is one of the largest and most rapidly growing populations, albeit diverse populations, of people in Canada, we have only some tools that are better than others, but no tool yet that helps us to address the issues of measurement bias, of diversity, and this leads to very serious problems in assessing equitably how well our healthcare organization is moving towards a very clear goal that it's set to achieve for itself. So Rick said, how about you come along to this study where we're trying to sort some of these things out? So in our current project, we have 3 primary aims to move forward some of that foundational work that Rick has just described for you, with an emphasis on equitable people-centered measurement. So the first aim is to further, thank you. Oh, here we go. Yes. So, here we go. So our first aim is to further develop and evaluate this methodology that Rick has just described. Thank you. In order to better help us determine, using some very specific measures and outcomes, basic questions like, how do we know what group people are in when and which groups they might be in simultaneously? Are you with me so far? Yeah, okay. So we are developing then, in our first objective, a method that will help us to calibrate this mixture CAT model. And what we're doing here is, first, we're seeking to establish a measurement model that applies these methods to assess existing pain and emotional well-being item banks that are already widely used across many areas of our health system. We're wanting to then use that information to help determine the number of latent classes. So how many classes actually matter when we're looking at these things? And how do we know how these classes interact with one another and under what conditions or circumstances? Then we want to estimate the class-specific model parameters by applying this particular approach that we've just described to a large and diverse sample, and then hopefully predict those latent classes by applying the logistic regression models that Rick has just described to 2 specific areas, looking at social determinants of health and other health indicators. So once we have calibrated the model, the next thing that we need to do is to evaluate it. And in order to accomplish this, we need to compare the predictive performance of, again, we're looking at 2 specific dimensions here, pain and emotional well-being trajectories over 6 months across different modalities. So using different types of approaches to see how these perform, again, with who and under what circumstances or conditions. And then once we think we have a mixture CAT model that's actually predictive of some of the things that we're hoping to see, we need to understand how it would be best used. And here we're using a learning alliance approach that I'll describe in a few moments to determine knowledge users' perspectives about how we could be using something like this. What would matter most to them, what they would expect to see when implementing this kind of an approach to assessing these factors in different settings and with different groups. So the first objective in calibrating the mixture CAT data is we're using 2 item banks from, I'm going to move here. So we're looking at, in calibrating the model, we're looking at using data coming to us from a variety of areas. So we have self-reported mental and physical health diagnoses, as well as self-reported healthcare utilization. That was, if you think back to that earlier slide where we have, where we had the clinical conditions in the previous study, we're using the same approach here. Then we're looking at social determinants of health by asking participants to respond to questions that come from 2 scales. So one is the SPARK tool. It might be a tool that would be of interest for a larger discussion in this group as well. SPARK stands for Screening for Poverty and Related Determinants to Improve Knowledge and Access to Resources. and also looking at the gender, pain, and expectations scale. Then, sort of coming back to that question that I raised earlier about perceived health and quality of life, we're taking items from existing banks that are already included in standardized assessment tools, some related to pain, some related to emotional well-being. So how are we going to do this? So the calibration of a CAT requires a sample of individuals that reflect, again, not just the median or the mean or the average, what we would expect to see, but in fact, the entire range of what's being measured. So all levels of pain, all levels of emotional well-being. So to achieve this, we're following the recommended practice to sample both general and clinical populations. Additionally, calibrating a mixture CAT requires a sample of people in variation in social determinants of health and health-related characteristics together. So thus, our samples and selection criteria include both a general population sample as well as a clinical sample of adults, and so over the age of 18, who are able to complete an online survey currently in English. So the general sample here that we see on this flow chart here is under our new sample, is an online panel of 5,000 adults in BC and Alberta who are recruited via social media via our e-health technology partner, Cambion. So, and that's the process that Rick has just described. He can demonstrate for us in a few moments. Using their digital health data platform, Cambion has the ability to recruit across multiple social media channels, following, of course, best practices for confidentiality. And we're having some interesting discussions as a team right now about how we engage with things like social media to ensure that we have a diverse sample, but not, for example, achieve such a wide reach that our sample includes bots. We also have a clinical sample here. And so our clinical sample is a sample of adults who are living at home with a chronic illness who are recruited from a variety of places. So the BC Office of Patient-Centered Measurement e-panel that includes participants who were recruited from a large provincial patient experience surveys are one of those groups. We also have the kidney disease patients in Alberta who have completed a consent to contact for prior to research, so the ePro kidney group, and the Health Quality Council of Alberta, which is, I think, an organization that a number of investigators here are familiar with already. So that's objective 2, and I'm looking at the time. So I'm going to move pretty quickly through this. So in addition to that approach, we're then going to work with a heterogeneous clinical cohort of 1,500 adults who live in BC in Alberta, using longitudinal measures over 12 months. So again, the pain and emotional well-being items, quality of life, healthcare experience, utilities, and use, and those social determinants of health. We are going to then apply those 4 measurement modalities that we've described. And with consent for this particular group, we'll also link to their using a personal health number to administrative health systems indicators that would help us to also understand a little bit more about the health service utilization and also the care trajectories of some patients. Again, thinking about the importance of taking a longitudinal approach, capturing what matters most to people at particular points in time, as well as at particular points over time. And then finally, we're going to seek to understand the use of the mixer CAT model. So this is where community engagement becomes most important, right? Because we know across just about all areas of research that's conducted here at CHÉOS that the successful implementation of any intervention, including this type of intervention, has to engage knowledge users in code design and development. And one of the ways that we're seeking to engage knowledge users here is through a methodology called a learning alliance. We're also going to be implementing some qualitative research methods that we'll speak to, I think, if we have time, but I'd like to move us a little bit. So our team who is working on this engagement reflects both areas of expertise, but also membership in communities and organizations that are most concerned with the mobilization of this new knowledge, right? And so we have people coming from academic organizations across Canada and internationally. We have knowledge users from within the health systems. We have patient partners, and we also have industry and government partners who are going to be working together over the course of the study to think meaningfully about what we are learning and how we can best apply this to the current work that's taking place in health systems, as well as how that work itself might be informed or transformed by the improvements in appropriate data collection. So this Learning Alliance methodology that we're using is one of the ways that we're wanting to both emphasize patient and partner engagement, but also a way to grapple with how we interpret the findings of this work in an ongoing way, quite particularly from an EDI perspective. So the Learning Alliance is comprised of people who are part of the research team, who are part of those government and health industry professionals, and patient and community partners. The Learning Alliance is more than just an advisory group to the study. They are really the doing group. So this is a group that will have very concrete tasks related both to our integrated knowledge translation plans, as well as our end of grant knowledge translation plans. And these will, of course, interact with other work that Rick has described that's previously ongoing. We have two subcommittees that advise the Learning Alliance. So the Learning Alliance is a decision-making entity. It's the doing group, but the Learning Alliance needs advice and support from others. So we have a patient engagement working group that is co-led by Maria Santana and Sandra Zielinski. We have other patient partners involved in this group as well. And their role is to really think about the applicability and the meaningfulness of what we are doing from the perspective of the patient, the person who is going to fill out these surveys and the person whose wants, needs, preferences, and priorities need to be best understood by this work that's happening. We also have an EDI subcommittee. And the EDI subcommittee is comprised of individuals who represent communities and organizations and services that support those communities across a variety of different aspects of identity and lived experience that matter most. Just one of the things that the EDI committee may be grappling with is when we look at some of our subscales that relate to gender, for example. We have, at the moment, when we look at how within the work that's happened to date, we understand very well that how people respond to different items on these scales can be predicted by, informed by, or mediated by that person's gender. But right now, the way we capture that information is very much along a binary. We know that gender is not a binary. We know that gender is a spectrum. And so how can we incorporate this learning about the heterogeneity across these different samples to people whose genders reflect that continuum outside of a binary? So that is, in brief, a tour of the project itself. We have some discussion questions that we're hoping to get some input from you about, but maybe at this point, it's best to pause for questions, see if you'd like a demonstration of what the mixture count looks like in practice. Yeah, so we'll pause there.